All right, so welcome everyone. I'm going to get us started here. My name is Kelly Kraft. I'm a program manager with Gilda's Club Quad Cities, and welcome to our COVID-19 vaccine workshop and Q&A. Just a little bit about Gilda's Club in case any of you haven't heard of us before, haven't joined in on anything with us before. We are a cancer support community that provides 100% free programming to anyone impacted by cancer. So that's cancer patients, cancer survivors, caregivers, friends, kids, anyone impacted. And we are super excited to have this workshop tonight. Just a couple of housekeeping things. I did mute everyone so that we can make sure to kind of get through this without a hitch and without background noise. And I would like everyone to make use of the chat function. So for all of our questions, because toward the end, we're going to have lots of time to answer some questions that are on all of our minds. So if you can, either at the bottom or the top of your screen, there's a little like chat bubble, a little square with a little arrow off the side that says chat. You can use that to chat in any questions, and I'll be monitoring those and feeding those to the doctor to be able to answer those. And if for some reason, if you have an issue with staying muted, there should be a little, it looks like an old-timey microphone on the bottom or top of your screen, depending on what you're using. And you can click that to stay muted. But if you have any questions, just let us know, chat them in. I'll be monitoring that throughout the night. And then otherwise, I will let the doctor take over and start his presentation, and then we'll you can add questions in throughout his presentation and after, and I'll ask him those questions and we'll get to them once he's done with his little presentation. Go
Wonderful.
ahead.
Okay, thanks very much, and good evening, everyone. I'm Dr. Vakalanka, and I'm one of the medical oncologists currently working with Unity Point Health on John Deere Road. And I came to the Quad Cities about a year and a half ago, but having said that, I'm fairly familiar with this area because I trained at the University of Iowa hospitals, and we used to have a lot of interaction between various community cancer physicians in the Quad Cities and the university hospitals, and had the opportunity of taking care of several of our patients in this community. And I'm so glad that I had the opportunity of talking to you guys about a very pertinent kind of an issue that seems to be affecting the majority of the country, if not the entire world. And that topic obviously is the COVID-19 infection. And in addition to the multiple problems that we had at the outset when the virus made its appearance almost nearly about a year ago now, we are at a phase where the viral infections continue to go on almost unimpeded. Having said that, though, the good things that seem to be happening right now is, in addition to trying to put in place certain mechanisms to reduce the chances of being infected and reduce the chances of transmitting the infection to other people, we are now in a situation where we could actually prevent the severity of the disease and also prevent long-term consequences of the viral infection. And that has largely happened as a result of the availability of 2 new vaccines over the last few weeks. And those vaccines are associated with significant benefits, and to the extent of reducing the risk of developing disease and severe symptoms by almost about 95%. And they also had an impact in reducing the long-term consequences of the viral infection. Now, clearly, the discussion about the vaccines today is going to be focused not only on the general aspect of the efficacy of the vaccine, the evolution of the vaccine, the mechanism of action of the vaccine, and maybe some of the logistics revolving around the administration of the vaccine in the local communities. But we also will try to kind of make it a little bit more targeted towards cancer patients. And as I'm a medical oncologist, that's going to be my area of expertise. And once I do a relatively short presentation about some of the basic facts related to the vaccine then you will all have an opportunity to ask me anything that's on your mind. So I'm looking forward to taking your questions, but let me start off with the presentation. So the first thing that we are obviously trying to do at this point is to start off with a PowerPoint presentation about the most important pressing question that we all have, which is, are we going to vaccinate our cancer patients, or do we not have to vaccinate our cancer patients? The reason this question has actually become a fairly pertinent kind of a question for most of us is because there is certainly a concern for most patients with cancer about the efficacy of the vaccine, because the vaccine had been tested largely in the general population, and that general population is a healthy general population. Most of them did not have a diagnosis of cancer, and most of them were fit and well to begin with. And the efficacy of the vaccine had been established in that specific population. It's a large population. When I say it is a specific population, by no stretch of imagination should we assume that this is a narrow population that has no relevance to the patients that we normally deal with who have underlying cancers. Although
excuse me, doctor. Sorry. Are you meaning to have your PowerPoint up right now?
Yes, I thought I did. Can you not see me?
I can just see you. Would you like, if it makes it easier, I can put the PowerPoint up on my screen. Would that make it easy? Oh, there it goes.
You found it?
There it goes. Now we can see it.
Okay, that's great. Okay, no problems. So that pertinent question about either vaccinating or not vaccinating of our patients was largely based on whether we can extrapolate the results that have been derived from the general trials that have been done in the general population. Can we actually take those same results and then translate those efficacy parameters into our cancer patients? That was the big reason as to why we wanted to target our presentation to address those questions. Now, there will be a lot of questions that we are trying to answer today. And essentially, some of those more fundamental questions are, what are the vaccines that are currently available? Is the vaccine safe to be administered, particularly in our cancer patients? And who should be getting the vaccine? Who should not be getting the vaccine? And as to why at all should we get the vaccine? Is that something that's going to be of some serious value to us? And if there are some side effects associated with the vaccine, is it worth getting the vaccine? And then we'll also try and address a lot more questions along the way. So to the question of which COVID vaccines are available right now, the FDA has approved 2 vaccines at this point. And those 2 vaccines are manufactured by Pfizer, one of them. And that got its approval a little bit ahead of the other vaccine, which is the Moderna vaccine. There are some slight differences between the 2 vaccines. Keep in mind that these vaccines were both considered to be mRNA vaccines. And I'll explain to you a little bit about the differences between these 2 vaccines as we go on, but also explain to you a little bit about how mRNA vaccines work. The Pfizer vaccine is authorized for people who are 16 years of age or older, and it is given in 2 doses, 3 weeks apart. Whereas the Moderna vaccine is authorized for people who are 18 years or older, and it is given in 2 doses again, but the vaccines are administered 4 weeks apart. And as I mentioned to you earlier on, both vaccines have been found to be effective in 90 to 95% of patients who received the vaccines. And, one other interesting thing about these vaccines is typically, even if 2 doses are administered, even after the first dose is administered, by the time they come in for the second dose, one of these clinical trials, or actually both these clinical trials, have been trying to test these individuals getting their vaccines prior to their second dosage to see whether there was any evidence of any infection at the time. And they found that the percentage of swabs, nasopharyngeal swabs that were done to demonstrate active infection with COVID-19 was less than 0.5%. Which suggests that even by the time they are actually due for their second vaccine, the first vaccine has already proven to be very effective. And that is reflected in the fact that the efficacy reaches almost about 95%. So going on to the next topic, which would essentially be to illustrate some of the basic anatomy structure of the virus itself. On the left side, we see a whole virus, and you can see that there are some purple kind of projections on the top, and these projections are called as the spike proteins. The yellow and the green structures are all other proteins that are embedded in the envelope of the virus itself. And as you do a cut section or a cross section of the virus, you can see that there is a coiled structure, which is actually the RNA of the virus itself. So this is a RNA virus, and the next slide will demonstrate to us a little bit more about what mRNA vaccine means and how this is actually manufactured. And mRNA is essentially a complex of chemicals that translates the genetic information that is available in the DNA. Now, the DNA information is translated into RNA, and this RNA is then transferred by what is called as mRNA. The M stands for messenger RNA into certain structures within the cells called ribosomes. And in the ribosomes, the information that is carried by the RNA is decrypted, and that information is used to manufacture certain proteins. And the human body does that, the virus does that, and most living organisms produce proteins this way. So it stimulates the body cells. When you actually vaccinate somebody, the mRNA that is actually present in the vaccine is coated with some kind of a lipid molecule. And this lipid-coated mRNA, when it is administered into the human body, it goes into certain cells called macrophages. And these macrophages are essential cells that are extremely important in the immune mechanisms that the body mounts against any infections. Now, the mRNA that is administered into individuals when they get their vaccination essentially consists of mRNA that codes for the spike protein that we have shown to you earlier, which is that purple bit that sticks on top of the virus. Now, that protein is manufactured as soon as this mRNA enters into these macrophages. And once the protein is produced by the macrophages, the body then mounts an immune response against that protein. And that immune response is not going to be nowhere as heavy or as severe or as serious or as intense as the response to the virus, which would have contained the same spike protein if it infected a human being. The difference essentially is that because we are taking only the spike protein and the virus is no longer able to defend itself and fight against the immune cells that are countering it, the degree of immunity that is being generated by the administration of the spike proteins is intense enough to produce a good level of immunity, but it is not too intense in order to cause the body to go through a lot of severe side effects or maybe disease-related symptoms, as would happen if you actually got a real infection. So once the immune responses are mounted, the RNA eventually gets destroyed. The cells that absorb the RNA get destroyed, and following the destruction of the cells, the RNA that comes out of the cells is also eventually destroyed by several mechanisms that take care of these proteins. Now, the other thing to also keep in mind, which is a common concern that I hear, is that these vaccines are obviously not using the live virus, so it cannot give somebody an active infection. And the other thing is that this mRNA is not going to be incorporated into the DNA of the normal cells of the body, which means that it's not going to be something that is going to be a permanent part of our constitution. Now, moving to the next aspect, which is certainly something that heavily weighs on the minds of most of our patients, is whether these vaccines are safe, because there was a great concern about the safety of the vaccines, whether it's wise to be administered, whether it is really something like a black magic that shouldn't really be administered to anybody. Now, the FDA is a reputed organization, and in many ways, it is considered to be the gold standard for monitoring the introduction of several technologies, several drugs, several medications in the United States, and is looked upon as being the go-to place, go-to authority across the world. So it has a great reputation, and it truly cares for the safety of the patients and goes through a lot of review process, culling all the safety data from these clinical trials. And depending on the situation that we are dealing with, grants an emergency use authorization only if it is convinced that the benefits are going to outweigh the potential risks for the patients. There is also an independent monitoring committee and advisory committee on immunization practices, which comprises of eminent physicians, eminent scientists, eminent researchers, and an independent data body, which also reviews all the safety data before actually recommending that the COVID-19 vaccine can be used for regular and routine purposes to reduce the risk of infections. And the process of monitoring the efficacy and also the safety of the vaccines doesn't end with the approval of the vaccine, but that continues with the monitoring of the safety as we move along. Keep in mind that the vaccine development is probably among the fastest that we have seen since the evolution of vaccines almost about 100 years ago now. And the fast evolution and the development of the vaccines doesn't seem to have been associated with any significant compromises in the safety part of it. But keep in mind, if we tested the vaccine in about 30,000 patients and we have nearly 300 million individuals that need to be vaccinated, there are going to be additional side effects or additional consequences and additional information that will be obtained as we embark on the mass vaccination. So that information is constantly being monitored, and that's also going to be available to us as we move along so that we can make necessary adjustments if need be. And then a question that probably should have been asked at the front, but a question that is important even at the later stages of the presentation is as to why is the vaccine so important? It is important because we have taken a huge toll, not only in this country, but also across the world, in terms of suffering heavy losses of life, long-term morbidities, financial losses, economic upheaval, and the world essentially has come to a standstill because of this viral infection, because of the rapidity of the spread and also the high level of transmission, the consequences of the viral infection, and the heavy death toll that certainly has happened as a result of the vulnerable population being affected by this virus. So the long-term consequences of this virus and the problems that I just narrated should really make it very obvious to us as to why vaccinating individuals at risk is going to be of some serious value in restoring some degree of normality to the country, if not the world. Now I'm showing some of the early pictures of some X-rays that have been done in patients, and this is actually a original study that was published by authors who were treating patients in China. This was way back in 2000. Okay, I shouldn't say way back, but it certainly looks like it is way back. This was in December 2019 that they presented problems with some of their patients being admitted on a routine basis with problems related to their breathing, shortness of breath, chest pains, coughing, so on and so forth. And those X-rays that you are seeing here are so heavily infiltrated with some whitish areas, and all these white areas are areas of congestion where the lung is trying to defend itself against the virus that enters the lungs. The upper part of the X-ray where the lung looks dark is how it needs to be, whereas in the middle part and in the lower part, you can see that almost about half of the lung, if not 3/4 of the lung, is filled with white material, which is essentially secretions and gunk that gets accumulated as a result of the infection. So the next slides that we are going to show you also demonstrate certain other organ changes that could happen as a result of the viral infection. And you can again see another X-ray which demonstrates similar features, but maybe not as impressive, but much more diffuse than what we have seen before. And this is a CT scan of the chest that we are seeing, where on a cross-sectional image, you can see that there are multiple areas which are looking like big blobs of white, which are sitting in the lungs, and they are occupying, more than 50% of the lung on this side, and maybe, more than 50% of the lung on the left side too. And this CT scan of the brain shows that there is a very dark area on the left side of the brain. And when I say left side, I know that it looks like it's on your right side, but we look at it, inversely. So this is the left half of the brain where the arrow is shown. And that area of the brain is looking black. And compare it to the other side, which is relatively normal, which is looking white. And all this black area is dead portions of the brain. It is because there is an increased risk of developing clots in the circulation of the brain, and that clot cuts off the blood supply to the brain, and that brain has essentially become dysfunctional, and patients develop serious problems with their brains no longer working as they should. And many patients develop edema or swelling of the brain, and they might develop problems with their breathing secondary to the various parts of the brain which control the breathing not working properly. Now, once we demonstrated how serious, how intense the potential consequences of the COVID-19 infection could be, let's move on to ask the question as to why the vaccine was not tested on people with cancer. And the broad answer to that question is that whenever you would want to test something that is new, whenever you want to test something that can potentially be of some significant adverse outcomes that can be associated with an untested intervention, you would want to test it on people who are considered to be normal, healthy, without any underlying problems. And cancer patients who might be receiving multiple treatments, whose immunity is suppressed by cancer itself, are not going to be at the top of the list to receive these vaccines, the side effects of which are unknown, which is the main reason why those early studies have not included patients who had cancer. And obviously, the other question is, if the original studies have not been tested on patients with cancer, should cancer patients and patients who have survived their cancer get the vaccine, because we don't have any information to back it up? Agreed that we don't have a lot of information. Having said that, though, there are many physicians and scientists and researchers who used all the information that is available within the clinical trials, but also managed to acquire some real-life experience as to what the downsides of administering the vaccine would be for cancer patients. And based on their recommendations, we have now accepted that patients who have cancer or a history of cancer should be okay getting the vaccine. There are some caveats to this assumption, and I'll talk to you a little bit more about those caveats in the next few slides. And the other thing that came up from the recommendations of the expert medical groups is that they actually say that patients with cancer should be prioritized for vaccination because their immune status is compromised and they are going to be more vulnerable and more prone to developing problems with COVID-19 infections, as we have already seen in patients who are elderly and in patients who are hospitalized, who are in nursing homes, who have comorbidities, being much more vulnerable to the effects of the COVID-19 infection. So cancer patients also fall into a similar kind of a category. So there are certain contraindications for the administration of the vaccine. If there is a specific set of patients or specific set of individuals who are allergic to a particular vaccine component, they should not be offered vaccination with that specific product. And we do have choices. The way the vaccines are actually manufactured is slightly different between Pfizer and Moderna. So we can certainly make inquiries with those companies to see whether, if you had any allergies to a particular vaccine in the past, we can make sure that the vaccine that's being administered doesn't contain the same component, which can increase the risk of you developing an allergic reaction from this vaccine. Now, there is also a common concern from many of our patients about when they should be getting their vaccine. There are certain groups of patients who are receiving either a stem cell transplant or alternatively something called as a CAR T-cell therapy. I won't go into the details of the CAR T-cell therapy. This is typically done for patients who might have an acute leukemia or something called as a diffuse large B-cell lymphoma. And in these patients, the immune system is either heavily suppressed because they don't want to develop, the physicians or the people who are managing their problems don't want the patients to start developing a rejection of the transplant. So they are put on immune suppressant medications, which will reduce the efficacy of the vaccines. And on the CAR T-cell therapy recipients, the immune response is hyperactive. And if they develop a idiosyncratic reaction or a severe allergic reaction once they are vaccinated, that can prove to be a problem. So those patients are essentially excluded. When I say excluded, it's not as if they're completely excluded from receiving the vaccine for the entire life, but we need to at least wait for about 3 months or so following the stem cell transplant or CAR T-cell therapy before receiving the vaccine. There is also another group of patients who might be on some heavy-duty chemotherapy, intense chemotherapy for an acute leukemia, for example. And in those patients, we may have to wait for about a couple of weeks or so for their blood counts to recover before administering the vaccine. But for the rest of the patients who are getting treatments for, say, something like breast cancer, lung cancer, colon cancer, so on and so forth, there is really no waiting period. And as soon as the vaccine becomes available, I think they should go ahead and get their vaccines. So some of the general side effects of the vaccine include pain at the site of the injection and tiredness, headaches, muscle and joint pains, chills, and fevers. And these are fairly common to the other vaccines like flu vaccines or maybe any other vaccines that you might have received. And the immune response that is generated by the administration of the vaccine is what causes those side effects. So side effects, although they're a pain, it might actually be an indication that the vaccine is actually working in your body. And these side effects typically go away within about a few days. So I wouldn't want you to think that there are going to be long-term consequences to the administration of the vaccine. So with regards to the logistics of the administration of the vaccine, it had been a difficult transition, particularly with everything else that's going on in the country that I don't have to comment about. There had been some degree of difficulty in getting the vaccines to the communities where it is actually needed. But I'm certain that the supply chains seem to be operating more efficiently at this point of time. Every state and every community has its own local and state public health guidelines. And we have implemented a tiered system of administration of the vaccine, and emergency responders and frontline workers were in tier 1. And the subsequent tiers typically include patients or individuals who are more than 65 years of age and individuals who have significant comorbidities, nursing home residents, so on and so forth. So as soon as we have some local guidelines available, and if you become eligible for the vaccine to be administered, I think you should go ahead and get it unless there is an exception that I mentioned to you before. And the changes to the distribution pattern of the vaccine and the availability of the vaccine, and also maybe the modifications that are being made about the implementation of the administration can be obtained by visiting your local health department. So that is probably the point where I'm going to stop my presentation, almost about 30 minutes into our evening today. And I'm very happy to take any questions that you might all have.
All right, so I'm going to unmute myself. I want to just allow people to ask some questions here. I'd like everybody to stay muted, but if you could use your chat function to chat some questions in. We do have a first one. If you want to stop sharing your screen.
Okay.
Looks like we still see there you are. Okay, so
sure.
We have one question so far. So as the doctor's answering these questions, just keep chatting questions in, and we'll get to as many as we can. We've got a whole half hour here. So the first question that we have is, I've heard the second dose of the vaccine has much worse side effects than the first. Is that true? And if so, what causes that?
Yeah, so that is to some extent true. The reason is when you get the first vaccine, the body is mounting a defense response. It's mounting an immune response to the spike protein or the mRNA that's administered. And by the time the second vaccine is administered, the body is already primed. It's almost as if it is ready to pounce on the second vaccine. And because the body has a lot more cells that are waiting to react to the second vaccine, there is a possibility that the second vaccine causes more side effects than the first one. Having said that, those side effects, again, are not likely to last for too long. And most of the times by taking some kind of, maybe doing some Tylenol or maybe doing some Benadryl or mitigating any side effects that you may experience from the vaccine, most of our patients seem to overcome these side effects within 3 to 4 days at the most. My wife had similar problems, which lasted for, say, 1 or 2 days, and then she was okay to get back to work.
Well, thank you. And we have quite a few questions coming in, so I'm going to try and get to as many of them as we can. Does taking an NSAID for pain and discomfort from the vaccine reduce the immune response? So should we not take an NSAID?
Sure. No, I don't think it would have any significant impact on the immune response. So I'm fine for any of you to take a non-steroidal if you experience side effects from the vaccine. The only caveat that I would have, on the assumption that most of you had been diagnosed with cancer, or you are concerned about, or you are actually on treatment for cancer, several of our patients, depending on the timing of the administration of the vaccine, could also be on treatments like chemotherapy, for example. And if that is the case, their blood counts could be low, and taking non-steroidals can sometimes cause problems with bleeding. It can also affect your kidney function. So be fairly conservative about how much non-steroidals you take. Taking non-steroidals, say, for a couple of days is not too bad, but if you took it at heavy doses for a week or 10 days, that can cause certain problems. And if you are in doubt, you can always check with your physician about it. And also keep in mind, Tylenol is also a very reasonable alternative to non-steroidals, but it doesn't affect your immunity though.
Thank you. I'm getting some questions that are really specific to very specific cancers and treatments. I'm going to go with the more general questions, and if we have time, we'll get back to those really specific ones. But and this, I don't know if you have the answer to this or if it depends on the person, but when is the optimum time to get the vaccine if getting chemo treatments?
Yeah, so that's a good question. And at this point of time, the honest answer is nobody really knows what the best time is, because there have been no clinical trials that were done. Having said that, there is at least a theoretical concern, which may or may not be true, that administration of the vaccine when patients are on chemotherapy can be associated with a slightly decreased immune response, because chemotherapy can cause that immune response to go down. So at this point of time, I'm typically advising my patients to get it around about the time that their chemotherapy gets started, either on the day or the day before, rather than get it, say, 10 days after the chemotherapy, where their immunity is really down. So that would be my general recommendation. There is not a heavy amount of evidence to prove that's the best way of doing it, but it makes a lot of logical sense.
Thank you. Another question here. Iowa Department of Public Health doesn't have great information on vaccine availability regarding timing outside of phase 1B. Do you have any guess for more of that, for more about timing?
Yeah, so my guess is as good as yours. And unfortunately, you can understand that there had been certain problems with the dissemination of the information, with the availability of the vaccines, the supply, the logistics, so on and so forth. and there is a lot that is left to be desired from the governmental agencies. And one other resource that you can fall back on is sometimes your primary care physician or maybe your hospital administration people might have some additional information that you can fall back on. Sometimes when patients come and talk to me about it, I go and talk to my managers or talk to my nursing staff who seem to have some more insights than what you might be able to get on the websites.
Thank you. Another question is, does chemo reduce the effectiveness of the vaccines?
Mm-hmm. As I mentioned just a minute ago, there is that concern that chemotherapy, generally speaking, reduces your immunity because it suppresses your blood counts. And the response to the vaccine is dependent on the body's ability to produce enough immune-related cells to respond to the vaccination. And if the cells are not going to respond well because they are being suppressed by the chemotherapy, the assumption is the effectiveness of the vaccine goes down. Having said that, we need to at least think about the fact that most chemotherapy drugs reduce what are called as the neutrophils, and there are other types of cells called lymphocytes, which are actually more important in mounting a good, robust immune response to the vaccines. So the lymphocyte count doesn't seem to be as much affected as the neutrophils with conventional chemotherapy. So for that reason, I don't think that vaccinations are going to truly be associated with a significant decrease in their effectiveness just because somebody is on chemotherapy. Having said that, there are certain types of treatment that are administered for certain types of cancers. For example, something like a lymphoma is treated with certain immunotherapy drugs, which reduces the lymphocyte count. And in those patients, there may be a higher concern that the vaccines might not be that effective. So this is again titrated to the individual. Broadly speaking, the answer is you should still go ahead and get the vaccine, because the alternative, where you are not vaccinated and where you may be susceptible to developing an infection, is much worse than maybe getting vaccinated and not having a 100% effective response.
All right, another question is, can someone on blood thinners get the vaccine?
Largely speaking, yes. Keep in mind something though, that these vaccines are intramuscular injections, and intramuscular injections are certainly associated with an increased risk of developing bleeding complications within the muscle where the vaccine is administered. But the needle is fairly small. It is not like a thick needle that's inserted into your skin or into the muscle. One thing that I almost always advise most of my patients who are on blood thinners is to apply some pressure at the surface where the vaccine is administered, so that the risk of any bleeding vessel causing uncontrolled bleeding will be kept to a minimum. And if you applied pressure for, say, 3 to 4 minutes at least after the vaccine, that might reduce the complications. But if anything, those complications are local complications, but should not be associated with any significant risk of bleeding elsewhere.
Right, another question. This specific person is wondering if they should not get the vaccine if their platelets are low. All their other numbers are good and they haven't had chemo for 5 months. So are there maybe like specific blood counts that should be taken into consideration? Yeah,
absolutely. So that's a good concern. That's a good question. And the platelet count is going to be essential to make a determination about the safety of the administration of the vaccines. But generally speaking, the risk of bleeding with something like the introduction of a relatively small, thin needle into the muzzle, which can result in heavy bleeding, is if the platelet count is, say, something less than 20,000, for example. Most of our patients, unless they're being actively treated with fairly aggressive chemotherapy, don't run those kinds of platelet counts. If somebody's platelet count is, say, more than 50,000, for example, that's absolutely fine. You shouldn't even be worried about getting the vaccine. I wouldn't see any significant downside to it. But as I mentioned before, for patients who are on blood thinners, just take those sensible precautions of applying some pressure on the site of the injection. If your platelet count is between 50 to 100,000, more than 100,000, zero problems. You are probably just going to have as few complications as anybody else with normal platelet counts. So those are the numbers that you at least need to have in your mind.
Thank you. Another question, can you talk a little bit about herd immunity and how long the vaccine is effective for?
So with regards to the question of herd immunity, that had been an issue that is fraught with multiple strong opinions on either side. Keep in mind that herd immunity is a process which is a situation where the general population in the society, if they are exposed to the infection at high enough numbers, develop an immunity to the infection over a period of time, because the majority of them would have been infected and would have recovered from the infection. Now, Sweden tried to do something like this many months ago, and Sweden, I trained in the UK, and I'm very familiar with the European way of medical treatments. And knowing Sweden pretty well, it is extraordinarily efficient in terms of their healthcare. When I say extraordinarily efficient, not necessarily that they do a better job of taking care of an individual patient, but at a societal level, they're much better than most other countries in the world, including the United States. They tried experimenting on herd immunity, but noticed that the number of people that are dying and the casualties from the COVID-19 infection was too high for them to achieve their goals, and the price that they have to pay is not something that the society can tolerate. So they again seem to have started kind of thinking about vaccinating their patients in order to achieve the immunity for its citizens. And in the United States, I truly believe that we have even more complications because there is a greater racial disparity, there is a greater economic disparity, there is a greater kind of a divide in terms of the uniformity of the availability of the healthcare resources in our country. So herd immunity is something that I do not think is going to be a very effective strategy in the United States. And I think you asked the other, I can't remember the second part of your question now.
Just if you have any idea on how long the vaccine lasts, the immunity from the vaccine.
So at this point of time, keep in mind that these vaccines started getting developed only about 8 to 9 months ago now. And based on the clinical trials, they followed these patients for about 4 to 5 months, and they found that the antibodies against the virus were present in those individuals that were vaccinated for at least 4 months, maybe slightly longer. So that also raises the question as to whether that immunity starts waning with passage of time, and that's a question to which we do not have an answer at this point. And also just to kind of mention to you that if you had an active COVID-19 infection and you recovered from it, the antibodies against the virus are also thought to be present in your body for about 4 to 5 months, which is more or less the same as what they found in their clinical studies.
Thank you. And I am getting some questions that are very specific about some really specific treatments and really specific amounts of time between treatments. And I just want to remind people to definitely talk to your doctors and your oncologists about this too. Sure. And this one is, does a patient with a blood cancer need to be treated differently if they come down with COVID?
Yeah. So it depends on what kind of a blood cancer we are talking about. There are several types, obviously. And as I mentioned to you before, if somebody has something like an acute leukemia, for example, and if they are being treated with aggressive chemotherapy for their acute leukemia, that causes a severe suppression of their bone marrow. And in those patients, vaccination should be delayed for at least about a couple of weeks or so until a couple of weeks after they complete their chemotherapy, so that we give the body enough time to recover from the bone marrow suppression from the chemotherapy. For most other blood cancers, for example, there are chronic leukemias, and those patients do not have aggressive chemotherapies administered to them. In those patients, they should not necessarily have to wait for a specific time, and they can just go ahead and get their vaccinations done.
Great. Another question, will the vaccine affect the effectiveness of the cancer treatments themselves?
As far as our knowledge goes, it's not going to interact in an adverse fashion against your treatments. So I think that we should not really worry too much about it at this point, based on obviously the available evidence, and we know that the evidence is not immense at this point of time, but based on what we know and based on the recommendations from world-leading experts, we don't have any concerns that it will have an adverse impact on the efficacy of your treatment.
Great. What about the vaccine effectiveness against new variants?
So that's a good question, and obviously a concern, because viruses mutate, and we know that from the multiple problems that we have with flu vaccines, which essentially change once every year or two, trying to incorporate new ingredients into the vaccine because the virus changes its shape and form over the passage of time. Now, the new variants have certainly been described in many countries, including South Africa, Brazil, and other countries. mRNA vaccine that is produced by Moderna seem to be fairly effective against those variants. And Moderna also is currently developing another strain, another mRNA, in order to specifically counter some of these variants. But based on their observation, they believe that the existing vaccines still provide a fairly high level of effectiveness against the variant COVID-19 infections.
Thank you. All right, and then do people who have had COVID already not need a vaccine? Are they already immune?
Yeah, so you bring up a very valid kind of a question and an important question. Keep in mind that most patients who have COVID-19 infections continue to have some degree of immunity for almost about 4 to 5 months after the infection. So for those reasons, I truly believe that you most likely will not get into serious problems with severe COVID-19 infections immediately after you have recovered from it. Having said that, there are certainly some case reports about patients being reinfected with COVID, and we need to kind of start teasing some of these terms that we are mentioning at this point, because infection doesn't translate to disease. If you're infected, you're carrying the infection, and you can potentially transmit the infection, but you might not necessarily develop a severe form of the disease. You may not develop symptoms, because 40% of patients who have COVID-19 infections are asymptomatic. So if you had a vaccine, for example, you could still harbor an infection. And if you had an infection, you can pass it around. But the advantage is that the vaccine reduces the chances of the infection producing severe symptoms, severe disease, and long-term consequences. The same is also likely to happen with patients who had a COVID-19 infection. And if they have recovered well, they should not really be prone to developing severe complications soon after their recovery. But you can still be prone to continuing to run the risk of being infected. Like, for example, you went to a crowded party or something, and the guy next door or next to you had a COVID-19 infection and he passes it on to you. You could carry that infection and you could transmit that infection to other people that you get in touch with. So for those reasons, I think wearing a mask and social distancing and avoiding heavily crowded places, so on and so forth, are still going to be of some value until we know that the entire society is no longer at a threat of developing serious problems with COVID-19.
Thank you. This individual had a prostate removal surgery a month ago. Should they postpone getting the vaccine, even though the cancer was contained in the prostate?
So I think that you should be okay to go ahead and get the vaccine as and when it becomes available. There is certainly some evidence to suggest that avoiding vaccine for a couple of weeks after any major surgery is advisable, not necessarily because there are going to be more complications or because the vaccine is going to be ineffective, but largely because if you are in the immediate post-operative period, and if you, for example, developed an infection from your surgery, and then you had the vaccine, say, the day after your surgery, it is sometimes very difficult to determine whether the fever or the symptoms that you developed after the vaccine are related to the vaccine as opposed to a possible complication from the surgery. So for those reasons, the national guidelines right now suggest that you need to avoid getting vaccinated after a major surgery for approximately a couple of weeks in order to give yourself time to recover fully from your operation.
Thanks. And forgive me if I mispronounce things here, but someone taking methotrexate weekly for RA, okay to get the vaccine?
So by and large, I think you should be okay to get the vaccine. Methotrexate certainly is considered to be an immune suppressant. It might, however, be worthwhile checking with your doctor, your rheumatologist, as to what your blood counts are. And if your blood counts are not seriously suppressed, I think you should be okay to go ahead and get the vaccine.
What about someone getting maintenance chemo every 3 weeks for recurring ovarian cancer?
So it depends on the type of chemotherapy, but by and large, chemotherapy for ovarian cancer doesn't cause severe depletion of the blood counts, and the immunosuppression is not as intense as with certain other regimes. And for most solid tumor malignancies receiving chemotherapy, such as for ovarian cancer, the recommendation is go ahead and get the vaccine. You don't have to wait.
Okay, another one, and keep chatting questions if you have some. We're running low. Everyone seems to react differently to the virus. This person's husband, who has a mild COPD, recovered in about 5 days with mild symptoms and no lingering problems. Were they just lucky? What are your thoughts?
So absolutely. When I go to the supermarket, I see a pile of apples and each apple is different from the other. Similarly, we are all different from each other, not only in how we look, but also in what goes on inside our bodies. And there are a lot of factors, external factors and internal factors, that determine how an individual is going to respond to a viral infection. One thing that we know for sure is that many patients, again, when you say COPD, there are individuals who have severe COPD, there are individuals who have mild COPD. And a mild COPD patient who has a relatively mild exposure to the infection might have absolutely no problems at all. And a severe COPD patient who has a serious exposure to an infection might end up on the ventilator and might never come out of the hospital. So somewhere in between, there are lots of permutations and combinations, and it's very difficult to determine who exactly turns out to have a better outcome as opposed to others who might have an adverse outcome. So it has to depend on the individual patient, their exposure, their ability to mount a good response, their medical care, so on and so forth.
Thank you. And is it okay to get the vaccine while getting radiation?
I think so. You should be fine. Radiation doesn't significantly suppress your immune status. And I don't think that the response that you mount against the vaccine is going to be seriously compromised as a result of your radiation.
Thank you. And we still have about 5 minutes left. I just got to our last question in the chat. So if anybody was wondering, had a question they didn't think we'd get time to get answered, you can chat that in now. If anyone is having a hard time with the chat function, you can unmute yourself to ask a question, but I would like to let you know that we're recording this and there is press on with us. So I just wanted to let you know before you unmute yourself. We'll give it a minute or two if anybody's typing some questions. Oh, we got one here. Oh, somebody say something?
Yeah, Kelly, this is Allison from Unity Point Health Trinity.
Hi.
Hi, hey, I would just like to comment real quickly per the question related to the accessibility of the vaccine. And I would just like to add and encourage everyone to continue to check the websites, to watch the news. The availability will be changing, as Dr. Vankalenka said, daily. I do know that in Illinois, Hy-Vee, Walgreens, and CVS is getting stock of vaccine, but it's very specific. So again, the most important thing you can do is really to keep an eye on your websites and the news to really understand when it will be available here locally. So just keep an eye.
Thanks, Allison.
Yeah, thanks for adding that in. All right, here's another one. You said herd immunity is not an option given time to reach, but we are still carriers, but we're still carriers with the vaccine. Given that, how long do you expect before we get back to normal?
You know, it's a good question and nobody really knows the answer. But the optimistic estimate, whether it's going to be ever realized or not, is that the present administration seems to be aiming at administering about 1 million vaccinations on a daily basis. So they are shooting for about 100 million individuals being vaccinated within the next 3 months or so. And that estimate had gone up to almost about 150 million, you know, within the same time frame. So on the assumption that half of the country essentially is going to be vaccinated within the next 3 months, if the same pace continues and if those targets are actually delivered, I'm anticipating that by the end of, you know, by the middle of this year, by summer this year maybe, we would have a large amount of population effectively vaccinated. But the administration's dreams of reaching those goals are hugely dependent on the enthusiasm from the public about receiving those vaccinations. And that's a question to which I do not have an answer at this point. But I think that by the end of this year, we will probably go back to some semblance of normality.
Thank you. We have about 2 minutes left, and I've got one more question here in the chat. Is it okay to get the vaccine while on targeted therapies? Specifically, this person says Tarceva, I believe.
Yeah, I think you should be fine with that. Tarceva is a good drug, and most patients tolerate this drug really well, and it doesn't cause significant impairment of their immunity, and their blood counts remain within the normal range mostly. So for all those reasons, if you're on Tarceva, I think you should be safe to go ahead and get the vaccine.
All right, well, that is the end of all the questions in our chat. I can give it a few more seconds to see if anybody's trying to chat anything and typing anything, but well, we did get a thank you. And that's something that I wanted to say too. Thank you so much, Doctor, for being on with us. And it was great information. We really, really appreciate it.
Absolutely. Anytime. I enjoyed participating in this meeting this evening and hope I answered your questions to the best of my ability, and good luck for everyone. Thank you.
All right. Thank you. Have a great night, everybody.
Okay. Bye-bye now.